Hi everyone. Thank you for watching our question and practice presentation. I'm Krista McHale, and along with my partner, Kara Wierakowski, we will be presenting a case on Cloxacillin versus Cefazolin in native valve MSSA infective endocarditis. We hope you enjoy. Here's a brief overview of our presentation. We will first introduce you to our patient with infective endocarditis. We will then give you a brief overview of the disease process, followed by the question and practice that we have identified. Then we will discuss the literature surrounding treatment options. Finally, we will apply this evidence to our patient and make a recommendation. We will then be happy to answer any questions you might have in the discussion board. Let's meet CM. She is a 32-year-old female who presented to the emergency department with fever, weakness, and hypotension. She is a current IV drug user of cocaine. Her medical history includes borderline personality disorder and ADHD. Upon arrival at the hospital, CM was found to be febrile with a temperature of 38.2 degrees. She was hypotensive with a blood pressure of 97/53. Her white blood cell count was elevated at 16.3, and her C-reactive protein was over 300. The physician then ordered a chest X-ray, urine culture, and blood cultures from 2 different sites. CM was admitted to the ICU, started on IV vasopressors, and given empiric antimicrobial therapy with ceftriaxone and vancomycin. The urine culture came back showing no bacterial growth. The preliminary blood cultures showed gram-positive cocci in clusters, presumed to be Staph aureus. The chest X-ray showed multiple nodular consolidations bilaterally. The physician also noted that CM had multiple skin lesions on her right dorsal palm, her right fifth finger, and left foot. CM was found to have a systolic ejection murmur on the aortic area. The plan at this time was to discontinue ceftriaxone and continue vancomycin until sensitivity reports returned. The physician ordered a transesophageal echocardiogram to investigate for endocarditis. Repeat blood cultures were ordered at 48 hours. The echocardiogram showed an elongated fibrillary attachment to the tricuspid valve measuring 16 by 3 millimeters. There was moderate tricuspid regurgitation. No vegetation was seen on the aortic or mitral valves. A chest CT confirmed the presence of septic emboli with cavitations. Final blood cultures also returned with growth of methicillin-sensitive Staphylococcus aureus. So finally, we have a diagnosis of tricuspid valve endocarditis with MSSA sepsis. The plan at this time was to discontinue vancomycin and initiate Cefazolin 2 grams IV every 8 hours. The duration of antimicrobial therapy was expected to be 6 weeks from the first negative blood culture. A repeat echo was scheduled in 3 months' time. So let's do a quick overview of infective endocarditis. It's an infection of the heart valves that occurs from trauma to the valve paired with bacteremia. The most common bacteria involved are streptococci, staphylococci, and enterococci. Risk factors include IV drug use, prosthetic heart valves, structural heart disease, having a cardiovascular implantable electronic device, age over 60, and hemodialysis. In the setting of bacteremia, like with CM, organisms can attach to and colonize valve tissue as well as forming complexes with fibrin and platelets. These complexes, or vegetations, are the perfect environment for bacteria to grow and also make it difficult for antibiotics to penetrate. As a systemic disease, endocarditis can result in the dislodgement of portions of the vegetation, resulting in septic emboli which can travel to and involve many organ systems. Treatment of culture-proven MSSA endocarditis in patients with no severe allergy to penicillin consists of cloxacillin 2 grams IV every 4 hours or cefazolin 2 grams IV every 8 hours. Treatment duration is 4 to 6 weeks in patients like CM with septic emboli. So revisiting our patient, CM, she was treated with a first-line antimicrobial for MSSA endocarditis. But after 4 weeks of cefazolin treatment, she started feeling unwell again. She had a fever, myalgia, and generally felt weak and tired. Labs showed that her CRP was trending up. It had been as low as 80, but had been increasing the past 10 days and was now 131. A repeat blood culture showed no bacteria, but a repeat TEE unfortunately showed that the tricuspid had a larger, bulkier vegetation than before and was now measuring 1.6 by 1.1 centimeter. Her physician could not identify any other cause of bacterial or viral infection which could explain CM's clinical presentation or rise in CRP. This, coupled with the concerning change on the TEE, led us to our question in practice. In a patient with native tricuspid valve MSSA infective endocarditis, with progressing vegetation despite 4 weeks of cefazolin therapy, benefit from switching to another antimicrobial agent.
My name is Kara, and I'm going to be taking us through the next portion of our presentation. Our research strategy involved first looking at bugs and drugs to determine the 2 treatment options for MSSA infective endocarditis. We next moved to RxTx, which validated these 2 treatment options. Although this reference provided more details for dosing and adverse effects, we were still unable to answer our QUIP. Next, we searched UpToDate, which introduced us to important primary literature that we later looked into. We then moved to PubMed and used the mesh words included on the slide. Selecting meta-analysis, RCT, and systematic review only provided a handful of results, so we unclicked these and scanned through 112 results. We used similar terms in Google Scholar and were able to generate a few more relevant articles. Many research articles cited other studies that we assessed to gain further evidence for our QUIP. First-line therapy for MSSA bacteremia as well as endocarditis includes cloxacillin or cefazolin. Comparing the two, cefazolin has many advantages over cloxacillin. It is well tolerated with considerably fewer adverse effects. Cefazolin dosing is more convenient at every 8 hours versus every 4 hours required for cloxacillin. If data shows that cefazolin has equal efficacy compared to cloxacillin, it's easy to see why it may be considered treatment of choice among clinicians. We could not find any RCTs or meta-analyses comparing these 2 agents in MSSA endocarditis. However, we were able to find several studies comparing these agents in MSSA bacteremia. A recent meta-analysis conducted by Monique Bedell and colleagues sought out to answer the following question. In adult patients with MSSA bacteremia, is cefazolin or cloxacillin superior for reducing 90-day mortality? This study included over 4,300 patients from 7 studies. 6 of the 7 studies were retrospective in design, and 1 was a prospective observational cohort. The meta-analysis concluded that cefazolin was associated with a lower 90-day all-cause mortality and a lower rate of treatment-associated adverse effects. However, it is important to note the limitations of these results. The conclusion is based primarily on retrospective cohort studies, which are inherently subject to selection bias. One retrospective cohort study accounted for over 70% of the patients in the meta-analysis. In this cohort study, important data was unavailable, including efficacy of the empiric therapy, source control data, antibiotic dosing, and total duration of antibiotic treatment. Endocarditis patients only accounted for 4% of the cefazolin group and 8% of the antistaphylococcal penicillin group, and deep-seated infections were not defined. Due to the design of the study, there is a potential for confounding by indication. Sicker patients, such as those with infective endocarditis or sepsis, may have received the antistaphylococcal penicillin over cefazolin. Of particular concern is whether we can generalize the results of this study to infected patients with high bacterial burden and limited source control. A large multi-center cohort study performed by Bay and colleagues compared the efficacy of cefazolin versus cloxacillin in the treatment of MSSA bacteremia in terms of mortality and relapse. The retrospective study included 354 patients with MSSA bacteremia who received cefazolin or cloxacillin as the predominant definitive antibiotic therapy. 90-day overall mortality was 27%. 20% with cefazolin and 30% with cloxacillin. After adjustment for risk factors at 90 days, there was no difference between the two groups with respect to mortality. Within 90 days, 3% of patients, 2% of cloxacillin, and 6% of the cefazolin group had relapse of Staph aureus infection after discontinuation of antibiotics. However, this difference was not statistically significant. All relapses in the cefazolin group were related to deep-seated infections. Given the observational nature of this study, it is possible that physician choice of treatment may contribute to selection bias. The authors discussed that patients with deep-seated infections, including endocarditis, were more likely to receive cloxacillin. Physicians may be reluctant to treat severe infections with cefazolin, which may account for higher mortality in cloxacillin patients. The authors concluded that cefazolin could be considered as first-line treatment for MSSA bacteremia without endocarditis or deep-seated infections. Although recent data has favored using cefazolin to treat MSSA bacteremia, research has not evaluated the clinical influence of a phenomenon known as the cefazolin inoculum effect. The cefazolin inoculum effect is defined as the prominent rise in the antibiotic minimum inhibitory concentration, or MIC, in a high inoculum environment compared with a standard inoculum. In other words, cefazolin may lose therapeutic efficacy when large numbers of bacteria are present. This phenomenon was first described in the 1970s when it was shown that some beta-lactamase producing strains of MSSA were able to readily hydrolyze cefazolin. Routine antimicrobial susceptibility testing uses a standard inoculum. However, deep-seated infections with high bacterial burden, such as infective endocarditis, may be better reflected using high inoculums. Unfortunately, this test is not performed routinely in microbiology labs. A study by Nannini and colleagues sought out to determine the identity and frequency of MSSA strains that are associated with the cefazolin inoculum effect. These strains were isolated from patients from several countries who had either had a complicated soft tissue infection, hospital-acquired pneumonia, bacteremia, or endocarditis. All strains were placed in 4 environments at low, standard, intermediate, and high inoculum. MICs were determined using a broth dilution method. The table here shows the percentage of MSSA strains that were inhibited by cefazolin at different inoculum concentrations. As you can see, the higher the inoculum concentration, the more strains are resistant to cefazolin. Of the 96 MSSA isolates, 19.2% demonstrated a pronounced inoculum effect, which was defined as the MIC greater than or equal to 16 microgram per mil. 2 strains demonstrated an inoculum effect at 64 microgram per mil, which is 4 times the breakpoint for non-susceptibility. Through DNA sequencing analysis, they determined that type A beta-lactamase producing MSSA demonstrated the highest inoculum effect. A second study by Nannini and colleagues compared the MICs of 4 antibiotics. This included 3 cephalosporins plus nafcillin. Nafcillin is an antistaphylococcal penicillin similar to cloxacillin. These 4 antibiotics were studied at high, intermediate, and standard inoculum of 3 strains of MSSA. At standard inoculum, the MICs for all antibiotics were at susceptible ranges. In the high inoculum environment, cefazolin demonstrated the highest inoculum effect. For the first MSSA strain, cefazolin had an MIC of 128 microgram per mil. Cefazolin was at the breakpoint susceptibility of 16 with the second strain. Nafcillin was unaffected by the inoculum size and retained its activity. No inoculum effect was seen for any antibiotic against the beta-lactamase negative MSSA strain. Although we need to be careful how we interpret in vitro studies, we can't ignore that several MSSA strains are highly resistant to cefazolin in high inoculum environments. It's important to note that vegetations and abscesses have been demonstrated to be between 10 to the power of 8 and 10 to the power of 11 CFU per mil, which is higher than the high inoculum environment in these in vitro studies. These in vitro studies provide us with important information that we can apply to clinical practice. If an infectious endocarditis patient happens to be infected with a type A beta-lactamase producing MSSA, cefazolin could lose its effect in treating bacteria within a large vegetation and may lead to treatment failure or relapse. There are case reports of treatment failure with cefazolin. However, the clinical implication of the inoculum effect is still unclear. A retrospective cohort study by Lee and colleagues looked at 113 MSSA bacteremic patients treated with cefazolin. The beta-lactamase gene of the isolates were sequenced, and patients whose isolates showed a 4 or more increase in cefazolin MIC at the high inoculum were assigned to the cefazolin inoculum effect, or CIE, positive group, and the remainder were assigned to the CIE negative group. Among the 113 isolates, 57.5% demonstrated the cefazolin inoculum effect. Persistent bacteremia was more common in the CIE positive group, and 67% of persistent MSSA bacteremia occurred in infections with high bacterial burden. The overall treatment failure rates between the groups were not statistically different. It is important to note that only a small number of endocarditis cases were included in this study, which limits its generalizability to our patient. The authors concluded that the CIE may be associated with persistent bacteremia if cefazolin is used for MSSA bacteremia in a high burden of infection.
Now, getting back to our question and practice. In a patient with native tricuspid valve MSSA infective endocarditis with progressing vegetation despite 4 weeks of cefazolin therapy benefit from switching to a different antibiotic? Our answer, maybe. Although the evidence seems to be leaning towards favoring cefazolin over cloxacillin for MSSA bacteremia, the quality of evidence remains a concern. Cefazolin clinical failures have been documented for treating deep-seated infections such as endocarditis, and we have a patient right in front of us who appears to be failing cefazolin therapy. The cefazolin inoculum effect has been demonstrated in several in vitro studies. The clinical importance of the inoculum effect has been proven difficult to assess, but we feel that based on our research, it cannot be ruled out. For our patient, we feel that it would be appropriate to discontinue cefazolin and initiate cloxacillin 2 grams IV every 4 hours, which is exactly what was done for CM. And within 72 hours of initiating cloxacillin, her CRP decreased from 130 to 49, and it continued to decrease thereafter. She has a follow-up echocardiogram scheduled after 6 weeks of cloxacillin therapy. Cardiology was also consulted to discuss if she was a candidate for surgical intervention. At the end of our research, we were unable to find a definitive answer to our question in practice, and sometimes there is no clear answer. But as pharmacists, we look at and appraise the best available evidence and use our clinical judgment to make the most informed decision for our patient. Much evidence points to there being no clinical difference between cefazolin and cloxacillin in the treatment of MSSA bacteremia. But limitations of existing research makes us cautious of extrapolating these results to patients with high bacterial burden, such as in endocarditis. Debate also still exists surrounding the cefazolin inoculum effect. Although well documented in vitro studies, its clinical relevancy is still largely unknown. What we do know is that our patient improved on cloxacillin. More evidence, ideally a large comparative randomized controlled trial, is needed to define the optimal antimicrobial therapy for other patients with MSSA infective endocarditis. Thank you for listening to our presentation, and we look forward to your questions on the discussion board.